And Dr. Lasko, you can just, go through, just let me know when you want me to go
Okay,
forward. I'll try to follow along with you.
I appreciate it. Okay, great. So if we can go to the next slide, that's me. I'm a chiropractic neurologist. I've been one for probably over 25 years. I practice in Pennsylvania. I almost specifically just see EDS patients. And the way my clinic is kind of set up, I call them intensives, where I only see a couple of patients a week. But I spend 2.5, 3.5 hours with each patient doing a real good neurologic exam and figuring out where in the brain the control mechanisms have kind of failed in a lot of these patients, and especially with the autonomics and the stabilizing areas in the body. A lot of this, I just feel a lot of the treatment for EDS patients has to be brain based, and that's kind of the way I formulated my practice for the last decade or so. I have no disclosures at all. I'm just my own person here in Quarryville. So most of you know this, and this really was kind of difficult to put together because I'm assuming there's some doctors, physical therapists, but there's also patients. So I'm trying to give a little bit for everybody. But generally, the EDS, there's 13 different types, and it's basically a heritable condition. It's a connective tissue disorder. Joint hypermobility, skin, very flexible. The tissues are generally fragile. And there's 13 genetic types. One is non-genetic, which with the hypermobile EDS, but I'm sure they're going to keep looking for it and they'll find some sort of genetic marker that's there for it. And especially since I've been treating EDS patients, there's definitely been an uptick in it. And even in the years before treating them, I know that I missed a bunch of them in the years before I really got into treating EDS. So it's something you should look for. And if we can go to the next slide. So first of all, like I said, it's really important to recognize it. You should be able to assess and do different either examinations or tests or things that you can say, hey, maybe this person does have EDS. I'm always for conservative treatment first. I think a lot of things could be taken care of if the doctor that's treating it, therapist that's treating it, really understands what's going on with the EDS patient. And it's much more than just, they move kind of funky and they can do different things. There's a lot of things that are comorbidities that at times, if it's not recognized, the EDS diagnosis could be missed. And this is one condition that definitely needs a lot of multidisciplinary care. So you don't need to know all things about EDS, but you should be able to at least recognize it. And if you're not sure, get it to somebody that does for the correct diagnosis or the correct treatment. You can go to the next slide. Thanks. So not going to spend a ton of time on this, but these are the 13 different types of EDS that's out there right now. Most of my clinic is the hypermobile or classic or classical like. I have seen a few periodontal. I've definitely seen some cardiac ones and the musculocontractual ones, but you just have to be aware that this is out there and it's something that you should look for if you're treating patients. We can go to the next slide. Thank you. So I learned this very early on that the patient or the family will either come in and say, listen, my child has EDS and this is what's going on. And a lot of them come in with, volumes of binders saying, what can I give you to try to help my son or daughter? Or the other person that comes in is I have all these things going on with me, nobody can seem to figure it out. I've been to cardiology, GI, psych docs, PTs, chiropractors, OTs. Nobody can really figure it out. And but I learned this very early on, that if the family knows about EDS, they're going to know more about it than you're ever going to. So just sit back and try to learn what they know. Um, what I've always found out, especially if somebody comes in with a bunch of different problems, you really have to think like EDS should really come to the forefront, because if somebody comes in and they're a little tacky, their heart's beating, they have gut problems, they don't sleep, their hands and feet are cold, they have anxiety, they have all of these different things. There's not a whole lot of pathologies that will present with such a multimodal type of a problem except for EDS. Metastasis is always, you always have to rule that out. And with any of this, always look at, you have to get all the pathology out first, all the hard pathologic things out. My experience has been EDS patients are definitely imaged, re-imaged, re-imaged, tested, retested, poke, probe, prodded, repoked, reprobed, reprodded. Most of the EDS patients that I see don't have hard neurologic lesions. And that's where I think a lot of the problems come with kind of treating them, because there's nothing that really jumps out on an MRI that says, that's it, or some sort of scan that says that's it. I like to call them like soft lesions or soft problems that present themselves, whether it's and we'll get into this a little bit more, whether it's with balance or autonomics or spatial awareness or vestibular or cognitive stuff. That's been my experience. So it's always good to rule out all the pathologic things, but most of the time, EDS patients, there's not one thing that's causing this. There's not a hard pathology somewhere that's causing all the things that this group has. If we can go to the next slide, please. Thank you. So and this again is a big umbrella, but most characteristics that I've seen, they're tall for their age, they're generally female. Usually things really start to go downhill during puberty or after some sort of trauma. Their joints move a lot more than what they should. So they have sprained ankles, hip problems. They could move their shoulders and things like that. For some reason, a lot of them are in gymnastics or dance. And obviously they're the ones that, because they can do all the things with their legs and arms, they're kind of in the center. But that's at least been my experience. I just see a lot of those type of patients. Their muscle mass is generally a little bit lower. Their posture's usually poor. Usually they have some anterior head carriage. Their backs might be a little kyphotic, so they're kind of humpback at times. They bruise easy, or they scar. They'll have stretch marks. And from my experience, it always seems like they have a bunch of things going on. And from my experience, if you really look at this early on, your autonomics are the first things that show in EDS patients. And I mean very, very, very young. So it's something when you're taking history, if a family member's there, a mom or dad, always ask about, how were they when they were young? And that means from birth, all the way up, because in my experience, I've seen a lot of patients that, yeah, they didn't sleep real well. They were picky eaters. They were always kind of cranky. They didn't meet a lot of their developmental goals. So those are things that you can kind of start saying, why. And if you're doing that in a history, and if they have all these different problems going on, again, it should pique an interest that maybe this person has a connective tissue disorder. So, next slide, please. Thank you. So, the Baton score, it's a real simple thing. It's not an end all be all, but it'll at least get you in the area that if you're not comfortable diagnosing them, it can at least give you an idea that, hey, maybe this person does have some sort of a connective tissue disorder, and get them to somebody that's comfortable with it, whether it's sending it to, if you're a physical therapist, chiropractor, whatever, maybe you can get them to somebody that's a little bit more understanding of what EDS is, or it's not. And this is kind of self-explanatory. You can, read it, and it's a good thing to print off. And I think the EDS Society has that, and you could print it off on their website. If we can go to the next one, please. So I put this one up because if you treat an EDS patient, you have to get really good at doing this. I couldn't find one that had knives coming in or axes, because you really have to juggle chainsaws if you're going to treat them, because if you're going to be treating a lot of different areas or a lot of different things that they have going on with them, and you do need to have a good network of people that understand EDS and all the comorbid things that come on with having that, because again, like the couple slides before, this has to be some sort of multidisciplinary care, because not one doc knows everything about EDS, nor can one doc treat EDS from, in my mind, autonomics all the way through cortical problems. It's very difficult to do that. So we need a good team for these patients to kind of go to and treat with. Next slide, please. So just a bit of caution. Again, I didn't put this one down, but I think it goes without saying that you need to rule out hard pathology first. I mean, that's first and foremost with everything. But in general, EDS patients move a lot in areas that they're not supposed to move, especially in the neck. And you just have to be careful with that, because I know in my history with EDS patients, I don't think there was an appreciation with some of the specialties that are out there that, that excessive motion in their neck isn't a real big thing. It's not that big a deal. That's a really important thing, because I've seen some people that have had different techniques done to the neck that have really damaged things, like they had difficulty breathing because they hit the third cervical nerve, upper cervical areas, your brainstem is there. So you just really have to be careful. And I think with the group of EDS patients in general, this is just my opinion, I think that word protocol should just be thrown out, because you look anywhere on an EDS website and the moniker is the zebra. I learned that very, very early on, that if you hear hoofbeats, it's not necessarily a horse, it could be a zebra. And that's rung true for a decade of me treating EDS patients, that the group the EDS group, just in general, is, even though you guys share a lot of the same comorbid problems, the reasoning behind it is individual to each person. And you guys should be treated that way to get the best results. So that's just me on the soapbox a little bit. It'll probably get worse as we go on, but that's fine. So it is a connective tissue disorder. So it affects all tissues except bone. So you really have to be careful treating it. I think it should be appreciated that EDS patients are different and they should be treated as such. The care should be individualized to that person. So if you're treating them, you really do have to be careful, just to make sure that you know what you're doing with them. And I just don't think you can treat an EDS patient like a 6'1", 210-pound guy. You have to know what you're dancing with an EDS patient, and they're going to have a ton of comorbidities. So multiple systems are going to be affected. So that's why the disciplinary actions, I just think, necessary. So, okay, let's go to the next one. So some of the comorbidities that you're going to see, and there's more of them. It's just, I only had a couple hours to talk, so we're just going to hit a couple. Hypermobility, not just in the neck, but especially in the neck. But they have it in their shoulders, their elbows, their fingers, wrists, SI joints, the rest of their spine. Tethered cord and Chiari is also fairly common. Autonomic dysfunction is, in my opinion, the first thing that really shows up, but I think it's the most missed because not a lot of people really understand autonomic function. And I think it's one of those things that are just kind of glanced over, because a lot of times patients or doctors don't know what to do with the autonomic dysfunction. Meaning, most of the times EDS patients are going to get, if you do have some sort of autonomic dysfunction, and if it's heart, blood pressure related or gut related, the default is going to be some sort of a med. The meds work, but I think there's different things that we could look at to see if we can help the autonomics. But autonomics is basically, I mean, it's blood delivery and it's oxygen delivery. So if you need blood or oxygen for a tissue to work, your autonomics have to work well before that tissue works. So that's definitely a big one. Movement disorders, I see a lot of that with EDS patients. And basically proprioceptive problems. Most EDS patients, they bump into things. They really don't know where they are in space. They'll drop things. They'll hit into things. They'll try to pick up a coffee cup and spill it. They'll always have to hold on to things as they're walking. Not all of them, but most of them do have some sort of spatial awareness problems. So hopefully we can touch on all of those today and see if there's any questions on them. So craniocervical problems. This still is a problem. And again, this is my personal opinion, just from treating a lot of people that have CCI or AAI. I have a DMX in my office, full disclosure. I use it on EDS patients to see how their neck is moving. I think it's a very important test to see how their neck is working. I think I think it's an important diagnostic tool, but I think just because you have some instability up there doesn't mean you automatically need surgical intervention. Because I've seen enough patients that have had clinical CCI and AAI that respond very, very well to care, and ultimately are able to go on without needing the surgical intervention, that's an option out there. If it's needed 110%, it has to be done. But I'm fairly conservative when it comes to treatment. I would like to I'd like to try everything else out before a surgical intervention is done. So CCI, basically, some motor delays. You might get some headaches. You might be a little uncoordinated. You might be clumsy. Uh, Neck pain, dizziness, vertigo, vision, hearing changes. I could tell you those things. Most EDS patients, if you really kind of do a good neuro exam, most of you have that. So I think the key thing is with CCI and AAI is, if you have that, does it clinically correlate to what you're experiencing? Because I can tell you from doing DMXs, I have done motion studies on the neck where patients had clinical instability at C1-2 and not have any of the symptoms that are presented in the next slide. I'm not ready to go there yet, but in the next slide, or CCI, they've had, and they didn't have any of those things. I've also done DMXs where the person wasn't clinically unstable, but had some of these changes and these symptoms. So again, the imaging, the exam, everything should correlate to where the problem is. And just because you have something doesn't necessarily mean it's causing everything that you're having. So from an exam standpoint, you might have some limb weakness. You might be hyperreflexic. You might have some pathologic reflexes, gait changes, vision and hearing could be altered. And the best imaging for it is an MRI. Even though that's static, you can do flexion extension and get different measurements, but that's still a static film, or the DMX. And the measurements we use are clivoaxial, Harris, and Grab Oaks. I'm sure there's other ones, but those are usually the big three. So we can go to the next one. And I'm just going to go through the three measurements that are done. Normal clivoaxial angle. If you're looking at this, you're looking at measurements between the dens, the tip of C2, and it's called the basion. It's the opening, the front part of the opening in your skull where the brainstem and the spinal cord would go through. And you measure them. And if the angles are between 150 and 140, that's usually okay. If anything is under 135 degrees, that's a pathologic measurement, and that's usually brainstem compression. So that does have to be looked at and evaluated in a correct manner. Next one, please. The Harris measurements, these are the ones I use with the motion study that I get, or that I do in my office. And it basically looks at the movement of the skull in relation to the second cervical vertebrae. And it measures front to back as well as up and down motion in the neck and in the upper cervical spine, when from neutral, when you look down, and also when you look up. And just generally, if any of those measurements are over 12 millimeters, so if, well, let me go to the next one. And then, or if there's a difference, I'm sorry, can you go back one? Sorry. When the other one is if there's a difference of more than 7 millimeters in one of those planes. So an example would be if you're in neutral and one of the measurements measures 6 millimeters, perfectly fine. Say you look down and one of the measurements goes to 2. That's perfectly fine, because 6, neither one of those are over 12. And say when you extend, that measurement goes to 10. Well, none of the measurements are over 12. but the difference between 2 millimeters and 10 millimeters is 8, and that's greater than 7 millimeters. So that would be indicative of a cranial cervical problem. Okay. And if any of those measurements are over 12, that's also an unstable upper neck. Okay. Now we can go to the next one. Thank you. Grab Oaks is another measurement. This is just done on MRI because we can't actually image the dura on an X-ray. So this is just a MRI view. So it's basically the distance between the dura to the basion to the back of C2. And if any of those measurements are more than 9 millimeters, that's indicative of a cranial cervical problem. I will say this, if you are getting a MRI, I have seen so many MRI reports that the reading starts at C2-3, and they don't even look at craniocervical or C1, C2 areas. Most of the times, if you're getting an MRI, it's for a disc problem. But if you're being referred for, if you have EDS and they're worried about some instability in the upper neck, please make sure that the referring doctor says, look at craniocervical area, look at atlantoaxial area, because most of the times, if you really look at some of the MRIs, the reading starts at C2-3. So just something, if you are going to be referring, make sure you say, please evaluate upper cervical area for hypermobility, or however you want to word it. But just make sure that they know what to look at. Okay, next slide, please. So atlantoaxial, that's C1 on C2. And again, the symptoms, neck pain, headaches, vertebral artery flow, you can really have some problems with vertebral artery flow if you see some instability at C1-2. But again, just because it's there, it has to clinically correlate to what you're experiencing. I will tell you a real quick story. I don't want to take too long here, but I actually had a patient where their neck was in neutral. Their heart rate would be 74 beats a minute, 76. I tipped them to one side. It stayed 76, 75, 74. I tipped her head to the right, and her heart rate went up to 130 beats a minute. That needed to be looked at. There was nothing that I was going to do that was going to help that. She was referred out for a surgical consult because that was a vertebral artery problem that was causing some significant autonomic problems. So that's kind of what I'm saying. Like, those are the type of things that should correlate to what the patient is experiencing. You can get dizziness, nausea, swallowing and breathing issues. Basically, atlantoaxial problems, you're going to be really tender in the upper part of the neck, right underneath the skull. They could really turn their heads right and left. Like, they could go past their shoulder with their chin. A lot of them will be hyper-reflexic. A lot of them may lose some sensations, like across the traps. And a rotational CT and a DMX are usually the best ways to diagnose that. We can go to the next one, please. Thank you. And here's just a picture of that. When you tip, the first one is with them tipping to the right. And it's kind of tough to see if you don't know what you're looking at, but C1 on the top view is overhanging about 4.5 millimeters. When they're tipping to the left, it overhangs about 3.5. So that's almost 9 millimeters worth of translation between C1 and C2. Anything over 7 is considered an unstable joint. Again, has to clinically correlate to what the person is experiencing, because I've done these studies and have seen measurements that were over 7, but they didn't have any problems in the upper, that would correlate to atlantoaxial problems. On the flip side, I've seen people with no overhang, and they did have atlantoaxial findings. So next slide, please.
So Elizabeth gave us a time check and said just to speed up a little bit, and we're gonna pause for no pauses for questions until the end. So we can
Okay.
stay on task. Okay.
Okay. I promise I could stay as late as we need, honest. Okay, so tethered cord is another one. It's basically where the lower part of the cord gets attached to the lumbar spine. And a lot of that, you can have problems with constipation, urinary problems, sexual dysfunction. The big thing is if you're hyperreflexic in the legs and your reflexes are normal in the upper extremities, and you have some of these things in the lower extremities and maybe pelvic floor, you should look at tethered cord. And the best way to look at that, even though MRI, sometimes it'll show up, sometimes it won't. I spoke to surgeons that basically said, hey, when I got in there, it was a lot worse than what the MRI showed. Urodynamic tests are also done to document this. So just something to think about if you have problems in the pelvic floor or in the lower extremities. Next one, please. And that's just a picture of that. You can see on the right, there's no connection to the spine, and on the left, there's no connection to the spine. On the right, you can see where it's kind of tethered. So when you do try to move down there, the spinal cord doesn't move the way it should within the spinal canal. Next slide, please. Okay, we're moving on then. So these are the big three. This is kind of where I dance with all the EDS patients that I see: autonomics, proprioceptive, and movement disorders. And we're going to hit the movement disorders first, or we're going to hit the autonomics first, sorry, because that's where I like to start with evaluating patients at all times. So we can go to the next slide, please. Okay, autonomics, again, trying to do this for docs that are here as well as patients, but autonomics, you basically have two systems: sympathetic, parasympathetic. There is an enteric system that gets into too much, so we're just going to keep it with the sympathetic, parasympathetic. Sympathetic, if you just think fight or flight, that's the easiest way to kind of look at it. The neurotransmitters that are used are acetylcholine and norepinephrine. And if the parasympathetic system, rest, digest, and repair, and the neurotransmitters that are used are acetylcholine. For the doctors out there, this is something that I found out a couple years ago, and it's really helped me with a couple of patients. It's not super common, but occasionally you'll see a person that has sympathetic findings. Maybe their heart rate's really high, or something like that. And you'll also have like parasympathetic findings. Maybe their pupils aren't real big. Maybe their gut is functioning, maybe faster. Maybe the motility is really quick. It's a good thing to do blood work to see how their acetylcholine is, because you could definitely have problems with the neurotransmitters if you're seeing both difficulties with sympathetics and parasympathetics. I don't see it a lot, but I've seen it enough where if I see that, I always refer them out to see how are the neurotransmitters functioning. Are you depleted in some, either the acetylcholine is usually the one that's down. So we can go to the next one. So this is something I found really early. A lot of patients think, and sometimes it's even doctors, that like this is an all or none system. Like you're either all sympathetic or you're all parasympathetic. And it really doesn't work like that. You need a good balance between the two for normal homeostatic function. And if you kind of look at it as gas pedals, is one of my colleagues kind of showed this to me, and it made a lot of sense. You need both of them to be pushing down on the gas a little bit for you to function in a correct manner. We need sympathetic tone. If we didn't have sympathetics firing, we wouldn't be here. We need parasympathetic tone. If we didn't have that, we wouldn't be here. So, but it's not an all on or all off system. So if you could think of it like that, this is going to make a lot more sense when you're evaluating patients, or when you're looking at them and you're examining them. Rarely is a system just running or one is just completely running and the other one is just out to lunch. You always have a little bit of gas on one or the other or both. Where the problem occurs is if one really over responds and really puts the gas pedal down. That's when you have some problems. And most of the time with EDS patients, it's been my experience, they bias toward that sympathetic drive. They definitely have more sympathetic tone than what a person should have. Okay, next, please. So increased sympathetics. If you think you're being chased, you guys are in the Pacific Northwest, by like a bear, that's what's going on. Your heart rate's high, your breathing is increased, your blood pressure might be up, your gut function is decreased, your pupils are a little bit blown out, you sweat more, you might be hyper reflexive, you can have some tremors, you might have a little bit higher immune response. So you can have maybe some MCAS stuff going on. And the next slide is basically if your parasympathetics are really kicking in, your heart rate's low, your blood pressure's kind of low, your pupils are kind of small, you have some increased GI function, and you increase glandular secretions. So you might have more spit in your mouth, stuff like that. You can go to the next one. So when you're talking about autonomics, the problem is when they start to get a dysfunction, you get something called dysautonomia. And there's a lot of causes for it, but EDS patients, in my experience, 30 years of practice, I've seen more dysautonomia in EDS patients, hands down, than any other group that I've ever seen. But you could have dysautonomia caused by autoimmune problems. You can have it if you have some instability in the upper neck. Diabetes can certainly cause it. Long COVID, I have seen, and just on a side note, really good results with long COVID patients that have had an increase in their dysautonomia symptoms. It really, long COVID, because it's a viral thing, really affects the brain and very specific areas of the brain, and it causes hypoperfusion of various areas in the brain, which we'll get into a little bit, really affect how your autonomics are controlled. You can have spinal cord injuries and different synucleinopathies like multi-systems atrophy, Parkinson's, and things like that. Next slide, please. So if dysautonomia can kiss every area of your entire body because it deals with blood delivery, it deals with basic homeostatic function. And so if your autonomics aren't exactly functioning great, and if, say, you're not delivering some blood up to the brain, you might get brain fog, you might get anxiety problems, you might get where your thoughts will just kind of run. You can have orthostatic problems. You can have temperature regulation problems. You can have immune problems, sleep, swallowing. Your autonomics kiss every part of your body. And if you're not delivering blood and oxygen to those areas, it's really tough for those areas to function. So you really have to address, I just think, comes a soapbox moment here. You really have to look at autonomic function first, because if you can't deliver blood to an area, if you just can't maintain basic homeostatic function, and say you try to move a person, or say you try to get them on a treadmill or something like that, or just exercise with therabands or do whatever, and if you're not delivering blood correctly, if your autonomics are not functioning correctly, how is that going to work? I mean, that's just in my head, the way I kind of think of treating EDS patients. And we get to this in a slide a little bit further down, but like, if you don't have good autonomic function, it's tough to do anything else before you can deliver blood to a tissue that you want to use to do a postural exercise or balance or do cognitive stuff. You need to be able to deliver blood first. So I'll get off my soapbox. Next slide, please. So a lot of autonomic tests are out there. We do a computerized autonomic test at our office that monitors autonomic function, seated, standing, Valsalva, regular breathing, deep breathing, balance tests, and stuff like that. But you can get autonomic tests. Boy, you can do a tilt table, but boy, oh boy, I wouldn't want that done to me if I had some postural stuff going on. So in my office, and I am fine with this, I do a poor man's tilt. Get blood pressure, heart rate laying down, stand them up, blood pressure, heart rate, see how you respond to gravity. And in my clinical, the way I feel, and I think with my understanding of this, that's good enough for me to get an idea of how that system is working. You could do gastric emptying test. You can do a QSART, which is a pseudomotor, kind of evaluates sweat glands. Thermoregulatory test that also evaluates sweat glands. And as we spoke about before, urodynamics for bladder function. Next page, please. So, orthostatic problems. I would be willing to say 90% of my patients come in and they say, I have POTS. I stand up and, this happens. There's certain criteria that you have to meet for an actual POTS diagnosis. And of those patients that come in, I would say maybe a third of them actually have POTS. They have some sort of orthostatic problem, but it's not necessarily POTS. I think that's thrown out there because that's kind of been, if you don't meet the criteria, you don't have POTS. With that, though, the guidelines for it is you have to have these orthostatic symptoms for more than 3 months. Your heart rate has to go up more than 30 beats if you're an adult, 40 if you're a child. And this is the thing, you can't have hypotension. Okay, so your heart rate can't, or your blood pressure, I'm sorry, can't decrease a lot. Like it can't go 120 over 80 down to 90 over 60. So your blood pressure can't tank. Okay, and your heart rate has to go over 120 beats a minute. So in my practice, somebody comes in and if they say, I've been feeling like this for 2.5 months, you stand them up and their heart rate goes up like 28 beats a minute, and but it only goes up from like 70 to like 107. I'm sorry, I'm going to call that POTS. I'm sorry, they didn't meet each perfect criteria, but they're pretty darn close, and they have enough there in my mind to say they have postural orthostatic tachycardia. This could be broken down into a hyperadrenergic POTS, which is where your heart rate goes up and your BP goes up. These patients are going to have some anxiety with this. And generally with blood, you're going to see high norepinephrine levels. you're going to see those through the roof. You can have neuropathic POTS where you actually have a peripheral nerve problem or a peripheral blood vessel problem where the vessels just don't constrict. So you pool blood in your extremities. If we can go to the next one, please. So orthostatic hypertension is exactly what that says. The blood pressure goes up more than 20 millimeters of mercury or above 140. The patient has to be normotensive though. So the person can't walk in with a blood pressure of 138/92 and they stand up and their blood pressure goes 142/98. Even though they're over 140, you didn't start with a normotensive person. And this is increased vascular resistance when you stand. So your arteries, veins are kind of clamping down, right? Orthostatic hypotension, 180 degrees opposite. It's where your blood pressure drops, your heart rate increases. And these are the patients that like to take a little nap on you occasionally because they're not pumping enough blood up north to keep the brain going. Vasovagal is where heart rate goes down, blood pressure goes down, and they take a little nap while you're doing this. And it's because you're not getting any blood up to your brain. And I just see this last one a lot, IST, inappropriate sinus tach. Your heart, if you take a piece of heart muscle, put it in a Petri dish, your heart has an inherent beat of about 100 beats a minute. If you're just sitting there watching reruns of The Office and your heart rate is, ticking away at $110, that's inappropriate sinus tach. I mean, you should at least get it looked at because that's just your sinus area on your heart is just not being inhibited to slow your heart rate down. So that has to be looked at as well. Can we go to the next slide? Yes, this is my favorite slide because most doctors will understand this slide if you're dealing with autonomic problems. I'm going to try to expand on it real quick. I'm going to try. But this is looking at your brainstem and how an area in your brainstem called the nucleus tractus solitarius, the NTS, gets input and then controls how your heart and how your blood vessels respond to that input. This is one picture of your carotid sinus, which is in the carotid artery, obviously. But that gives input into this NTS to let you know what the pressure is there. This nucleus tractus solitarius, if you think of it as kind of like a post office, because it gets a bunch of different inputs, but in this one, we're just going to do the carotid sinus. It talks to, so the input comes in from the carotid sinus, and your NTS sends input into the area called the NA, that's the nucleus ambiguous, that's the nucleus for the vagus nerve. And when you excite the vagus nerve, you slow the heart rate down. All right. The other branch, the NTS, sends something to this area called the CVLM, and this is more for docs, but I'm going to throw it out there, the caudoventrolateral medullary area. And this is really key because this is where the magic happens in the brain up. It inhibits, for normal function, it inhibits this rostroventrolateral medullary area, the RVLM. That is the sympathetic nucleus that controls, you can see the little lines that go over. It excites the heart and it excites the IML, that's to the left, so your blood vessels will constrict. Now, in my head, the way I look at this is where the problem comes, and that NTS gets sensory input from so many different areas, okay? It's not just the carotid sinus or the baroref or the chemoreflex. it gets input from a bunch of different areas. And I look at it as a post office. So it gets all this input coming in. And if everything coming in is addressed correctly, if there's a stamp on it, the address is correct, the zip code is correct, it can function in a normal way to get the mail out. So in this, it can control the heart and the blood vessels in a correct manner so you function normally. If the input to that area isn't real good, or if it's abnormal, if the zip code isn't on it, if the return address isn't on it, if the postage is not correct, the post office starts to break down and you don't get the mail. In this situation, if the input is bad, the output to these areas starts to malfunction. And the one that usually crashes is that CVLM firing to the RVLM, because that is what inhibits your sympathetics from running amok, from just doing whatever they want to do. So if the input into this NTS is not good, the output to control how your sympathetics work cannot be regulated or modulated or inhibited. And that's going to be really important for treatment, because if you don't, I want to say, appreciate that, if you don't appreciate that, sometimes you could do some things from a sensory standpoint, like exercises, vestibular stuff, just general somatosensory stuff. And if you're not getting the correct output from that NTS to regulate your sympathetics, you could actually be causing more problems in the system than what you're trying to help. And I'm going to get into that a little bit more, because that's where this brain based therapies kind of come in. Hey, just real quick, I have a question. And I've asked this to a lot of people, and this is more for the doctors. What is the parasympathetic nerve that controls blood vessel contractibility? The parasympathetic nerve. You don't have to write it down, but I ask this, a lot of people are not familiar with this. And this is why brain-based stuff is really, really important. And I'll let the doctors or therapists that are here ponder that for a second or two. But there is none. There's no parasympathetic innervation to your peripheral arteries and veins. So how can you change things like blood pressure, blood delivery, if your sympathetics are firing and your blood vessels are constricted? How can you get them to relax and deliver blood better if there's no parasympathetic innervation for them to vasodilate? It has to be coming from that CVLM to inhibit the firing of that RVLM, which is the sympathetic nucleus, to relax if you want those blood vessels, or to get them to vasodilate. Because there isn't a parasympathetic innervation to peripheral arteries and veins. There's some around the heart, there's some around the sex organs, and there's some in the brain. But for peripheral, arms, legs, that type of area, there's no parasympathetic innervation to control blood vessels. This has to be done from the brain. Okay. All right. Next slide, please. Or next two slides, I guess.
See.
Thank you very much. So movement disorders. I just break these down into two types. You're either moving too much or you're moving really slow when you want to move. So they're hyperkinetic or they're hypokinetic. Things like tics, tremors, myoclonus. If you always have that internal feeling like you have to move, dystonias, if you have reflexes, that's a hyperkinetic problem. That's a that is a movement disorder. And the hypokinetic are things like posturing, where like your head might be stuck to the right or to the left. You're bradykinetic, meaning you don't move very fluidly. Like if somebody would ask you to do like a finger to nose and they just go, hey, go ahead and do this, touch your nose, and you're like molasses in January trying to get to your nose. That's a movement disorder. It's just a hypokinetic, meaning you're not moving very quick, like decrease initiating movement, or the amplitudes, or you freeze when you're trying to move. Your reflexes will probably be decreased. So next slide, please. Generally, if you think movement disorders, you have to think basal ganglia. Cerebellum is involved in it, but most of the time it is the basal ganglia. And that's something that, from an evaluation standpoint, the basal ganglia runs a lot of things. It could have influences on autonomics. It can have influences on proprioceptive inputs, definitely moving. So if we can go to the next slide, please. So this is also one of my favorite slides, because my children said you could never make a slide with all this stuff, and I did it. So I'm really proud of that. But generally, the output of your basal ganglia is inhibitory. And this is a tough concept to get. So if your basal ganglia is working well, it doesn't allow you to move until the brain says, hey, I want to pick up the coffee that's next to me and have a drink and put it back down. So you should be able to sit there like a statue if your basal ganglia works pretty well. You shouldn't have to fidget your feet, move your fingers, adjust your neck, do all this stuff at all times. That's a movement disorder. And the output, again, I'm going to say the output of your basal ganglia is tonically, meaning it's always inhibiting your moving. The only way it gets released, the only way you move, is if you get a thought to pick up the coffee, pick up the pen. A loop comes in and says, what muscles do I need to use to pick up the pen? It loops around that basal ganglia and says, you need to do this, 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 and this. Everything else should be still. If you're the type of person, and I see this a lot with EDS patients, if you move one arm and say something else in your body moves, or if you're trying to do certain activities and you have to kind of move, like say I'm reaching for something and your neck tilts, or you have to move the other arm, or if you sit there and you always have to fidget, that's a basal ganglionic area that has to be addressed. And there's various areas, if you have problems in these basal ganglia areas, that with a good examination, you could tease out, is it a problem with the input? Is it a problem with the second neuron that gets excited to inhibit things? Like that's in my head, that's how I evaluate a person that has a movement disorder. And some of you probably caught this, but if you remember the autonomics, what was the one area that really kind of told you how your sympathetics were going to work? It's that inhibitory mechanism, right? From that CVLM to the RVLM. Like if that doesn't work, you're going to have some higher sympathetic tone. There's other inputs that come in there. There's other areas of the brainstem that have effects on this. This is just keeping it very simple. But the problem is a lack of inhibition, right? If you don't inhibit that nucleus that excites the sympathetics, your sympathetics are going to run. If you don't inhibit the output of your, if your basal ganglia doesn't inhibit the output, you're going to move when you don't want to move, right? So the problem with a lot of these things are a lack of inhibition, meaning the brain isn't regulating these areas in a correct manner. And that's where you see these, I call them escapes of the system. You move when you don't want to, your heart rate's high, you're sympathetically driven. It's because your system isn't working in a correct manner to create those inhibitory mechanisms. Okay, that was a lot. Next slide, please. So I just said this. Basal ganglia, constant inhibition of the motor system. We can only volitionally move, and that means like I want to move when inhibition is released. And there's 3 pathways up there. This was not the time or place to get into all of them. That could be a seminar on itself. So this is where it gets really cool, because as you start going from brainstem to cerebellum to vestibular to midbrain to tectal to tegmental, these are all brain areas, to basal ganglia, each rung on the ladder that's above kind of controls the one that's below it. It kind of is a hierarchy of control, kind of like a ladder. The person on the top is kind of the big dog. The one on the bottom is the one who has to look up, right? So your basal ganglia connects to 5 really big areas. It connects to the thalamus, which again, this is more for doctors that are here, the people that would treat. But that gives the input into your motor and sensory areas for body tone and telling the brain what to move, what areas need to move to get from point A to point B. It goes to your midbrain in your superior colliculus for eye movements. Rhetorical question, but how many EDS patients have a little bit of nystagmus, can't focus on things well, they can't stabilize their eyes in one spot, they have problems reading where they'll jump around the page. Big word, pedunculopontine nucleus, that's your motor center. That's the thing that patterns gait, orientating responses, orientating behaviors, postural things. Your reticular formation, it's a huge nucleus that goes from brainstem almost into the upper cervical cord for pain, muscle tone, posture. It has some autonomic controls in it. And it goes to your hypothalamus for autonomic control. So just think about this. If you lose the ability of your basal ganglia to inhibit its output and it kind of lets things play, anything that it's connected to is not going to function very well because it's going to be allowed to escape. It's going to be allowed to kind of run without anybody watching it. And that's where you see these different problems with eye motions, postural stuff, reflexive, things like how many EDS patients startle when they hear a loud noise? I mean, 80% of you, and I'm probably 10% short, or maybe 19% short. How many of you have difficulty inhibiting pain and inhibiting things like that? It's a lack of inhibition from these various areas in the brain that don't allow your system to function in a correct manner or as correct as it can be, so you can have a good response to living on this earth. Okay, next one, please. So just like you had the inputs into that NTS, that little post office that I talked about, these are the inputs that go into your basal ganglia. So going from left to right, generally, auditory, somatosensory, visual inputs, you have your eye motions, you have your deep senses like proprioception, you have cerebellar input, you have vestibular input that eventually gets to your basal ganglia. If this input is not correct, and if something is abnormal coming in, it's really hard to have normal function coming out of that basal ganglia. And the basal ganglia, if you look at the outputs, again, we touched on all of them, going straight down from it. Eye movements, you get inputs to the thalamus, you get inputs to the brainstem, which control posture, how you move, how you stabilize yourself. Basal ganglia is a big, big area that, in my opinion, if it's not being evaluated, you're missing an area of therapeutics that you can give to the EDS patients that can really be beneficial to them. My experience, a lot of people don't know how to evaluate that basal ganglia because the default a lot of times is, let's just give them GABA if they are moving kind of too much on one side, or let's do Botox. I might be getting on a soapbox here again, or give them Botox to neck muscles to try to shut them down. The problem isn't that they don't have enough GABA. The problem isn't that the neck muscles are too tight. It's the problem is the basal ganglia isn't functioning correctly. And that is a GABAergic thing. But if you have a tremor, this is my left hand, if you have a little tremor or a movement disorder on the left side, if you give GABA, the basal ganglia that would be affected by that would probably be on the right side. Are you giving them right-sided GABA? Because that's where the problem is. Or does GABA go throughout? It goes throughout the whole system, right? So what I've seen is it'll take care of the tremor or the movement disorder on the left side. Guess what happens to this arm or leg? You get hypokinetic because you're inhibiting it more, right? You're inhibiting it more because of GABA. We should be able to discern what area in that basal ganglia is causing the tremor or the movement disorder on the left side, come up with therapeutics that can specifically target that area of the basal ganglia and see what the results are. Okay. Off my soapbox. Okay. All right. Next slide, please. Next slide again. I'm going to be done by 7:30-ish, promise. So proprioception, EDS patients really don't know where they are in space. And if you really think about it, why? Like, why? Why don't they know where they are in space? Why do they bump into things? Why do they maybe walk very slowly? Why do they walk in an abnormal fashion? Proprioceptors, they're in muscle, ligaments, tendons, joints. Isn't that all soft tissue? Right? Isn't that connective tissue? Where's the problem with EDS patients? It's a connective tissue disorder, right? So these systems, all the muscles, ligaments, these proprioceptors, they are so connected with things like your visual system and your vestibular system. And it helps with the feedback to your brain to say the command that you gave me to pick up my coffee and take a sip, every time I'm moving, as I'm moving, I'm giving that brain feedback to say, am I on the right track? Okay. And if you're not, the brain has to correct it and correct it and correct it until you get to the coffee. Hopefully you don't knock the coffee off the table, knock the teacup off the table, knock the juice cup off the table, knock whatever off the table, bump into the door jamb as you're walking through it. Okay. So really start, I think a lot of the docs and the therapists that are here, hopefully this has given you a little better appreciation of why these patients don't exactly do great when they're up in space, because they really don't know where they are in space because their proprioceptors are bad because they have EDS. We go to the next slide, please. So I'm going to go through this real quick because this is really more for docs and you could look it over. But these type of fiber types, you have 1A that goes to length of muscle. Group 2 is for static muscle length, so at rest. Golgi tendons are 1Bs. They tell how much resistance is on a limb. And the Ruffini and the Pannicinian corpuscles are for joint position sense, especially when you get to that end range of movement. We go to the next one, please. So again, more for the doctors that are here, but patients are probably going to appreciate this. Proprioception, it's involved in motor coordination. It lets the system know where the body is as you're moving, posture, balance, and spatial awareness. And there's pathways that these very specifically go in. The non-conscious are through the dorsal spinal cerebellar tracts. The conscious are through the dorsal column medial lemniscus. They're just two different pathways. And again, from an examination standpoint, doctors, therapists, people like that, we should be able to tease out where is the system faulty and hopefully be able to target specific areas, treat, reevaluate, did we get the correct output that we want? Okay, next slide, please. Oh my, oh, I'm telling you, we're gonna be done by 7:30. Okay, so this is the way I think of EDS, and I'm probably gonna go rogue here a little bit, but that's okay. We're a multimodal system. Like our brain gets input from all different sensory aspects. It has feedback loops up there to make sure the input is processed correctly so we can get a good output. And it continually integrates from brainstem all the way up to the cortex. I read somewhere, I wish I would have remembered which article it was, but every second, there's 120 quadrillion neural impulses in the brain. 120 quadrillion. I don't know how many zeros that is, but it's a lot. So everything is integrated. All of this input we get has to be integrated so we can get a good output. But I think a lot of people just think the output is motor, like how do you move? How do you get from point A to point B? Motor is autonomic. Your autonomic system is a motor system. So is your endocrine function. All the hormones and all of that stuff, that's a motor system. Okay, next page, please. So what builds this neural brain that we get? It's sensory input. It is sensory input from all aspects of, I mean, me talking to you, you're getting sensory input, and I hope it's changing some neural connections up in the brain, maybe for better understanding, maybe for thinking of different questions, maybe for any sensory input can change brain function for good or for bad. The brain, I'm telling you, the brain could care less what comes in. It's going to process it and give you some sort of output. Okay, but the sensory input is the key thing. Next slide, please. Okay, so this is where I think the rubber's starting to meet the road. Is the most constant input humans have is resisting gravity and moving. Everybody always says vision. I could close my eyes and somebody could tell me what the slide is and I could have talked about it. I didn't even have to see the slides. Most of us don't taste very well. We don't smell very well. We could inhibit the clock that's ticking behind us. So all of those systems, all of those senses, they're important. We need them. But that input we get from muscle and joint resisting gravity is super important. And it literally drives our brain to make us us. There's other inputs. I'm not saying that's the only thing, but the most constant is from resisting gravity and moving. Example, when everybody goes to sleep tonight, you're not going to hear the clock. You're not going to see anything. You're not going to smell anything. You're not going to taste anything. But your body is getting input from one arm being tucked up under your pillow and the other one being straight. You're getting input from that. You're getting input from your gut. You're getting input from your heart. You're getting input from your lungs and your chest moving. All this is sensory in all of it is sensory input. Can we go to the next one, please? So I'm going to give you a quick example. Oh, I got a minute. Okay. All right, here we go. So I think sensory inputs, the mismatch of sensory inputs from an EDS patient leads to abnormal processing in the brain. And I think at the core, this is why EDS patients have so many comorbid things going on, because this incorrect input can alter nervous system function. It leads to an abnormal motor output. Real quick example, and I do this one in my office, is I don't have EDS. If I want to turn and look 45 degrees to my left and look at that lamp, spatially, I know where that lamp is in space. I'm going to turn, my eyes know where it is. My neck muscles are going to contract 45 degrees, whatever that tension is. My vestibular system sloshes fluid 45 degrees. Everything matches. The brain goes, cool, you got it. I don't have to think about it. What I thought was going to happen, the feedback matched it. I'm good. Let's do an EDS patient. Okay, say they're moving a little too much in the upper part of the neck. When they turn, how much does C1 rotate on C2? Is it 45 degrees? Could be. Could it be 50? Could it be 48? Could it be 42? Right? Where do your eyes go? Do your eyes listen to what your neck is saying? Or do you, hopefully you know where that lamp is, so your eyes go there. So what does your vestibular system listen to? Does it listen to how much the neck is moving or your eyes? Because you have things like vestibular ocular reflexes. You have vestibular colic, which is the neck. You have cervical colic. You have cervical ocular reflexes. Bottom line is, the brain said move 45 degrees to look at the lamp. What's the feedback? It doesn't match. Is that a nice calm brain that can go, I'm going to take 5 because you got it? Nope, it's always got to be on the job trying to figure out what that input is, because it never feeds back the same. Let's say you're fused, right? So I'm supposed to go like this to get to the lamp. If you're fused at C1-2, that forced 45 degrees of rotation comes from C1 on C2. So what input are you getting from C1, C2 if you have to turn 45 degrees? Because there's a big difference in turning like this versus turning like this. I hope you could see that. This versus this to get to 45 to look at the lamp. Does that input match? Nope. The brain goes, I got to keep an eye on this, because what I expect isn't coming back, right? Does the brain wire correctly if it's never getting the same input, or is it just rattling around up there trying to figure out what the heck's going on? I would think the latter, okay? Is that going to be good neural function coming out of that area? No, no. Next slide, please. I'm 3 minutes late. Darn it. So for us to function correctly, you need more excitatory outputs or inhibitory outputs for you to function better. So when you have a good functioning brain, next slide, you need inhibitory mechanisms, right? You need something to shut that system down, because when you lose inhibition, you have escapes. And I just noticed some of the things, somebody mentioned ADHD, I think, in one of the chats. Most EDS patients that I see are ADHD-like. They have high anxiety. Their thoughts just keep going. They can't shut things down. They can't just, sit by the pool with a little drink and an umbrella. They think, where's the shark going to jump out at me from? Is the moose behind me? They could never inhibit that system. A good functioning system, I'm driving down the road, somebody cuts me off, I'm going to lock up the brakes. My heart rate's going to go up. I might feel nauseated. My blood pressure is going to go up. A verbal thing might come out, maybe even a hand gesture. You never know. But if my brain's functioning well, I assess the situation. Everybody okay in the car? The guy waves, apologizes. I'm like, okay. And I go get pizza with the kids or whatever we're doing. That's a good inhibitory system. It kicked in when it was needed. It was shut down. That fight or flight was shut down when it wasn't needed. Bad functioning system, somebody cuts you off, you go through the same scenario, and you follow the guy 20 blocks and want to get out of the car and get in a fight with them. No inhibition, right? So think about all of these systems that we went over, and almost every, and I'm going to say is every comorbid thing that EDS patients have, and I mean from immune function up to heart rate, gut, brain fog, it's a lack of your system being able to inhibit things. And that's based on the input that EDSers have. And it's not a correct input because your connective tissue doesn't allow you to move in a correct manner. And I just think, we can probably go to the next slide. I just think we have to, when you lose all these inhibitory influences, you get escapes of these neural pathways, and it causes things like POTS, tremors, dystonia, GI stuff. Those are the comorbidities of EDS. Next slide, please. So this is how I look at patients, and this, I hope this doesn't step on anybody's toes, but if your autonomics are not working correctly, it's really tough to do anything from a physical standpoint if your autonomics are not functioning correctly. And if you're moving a person, or if you're doing some sort of therapy or whatever, because I've messed this up enough times, and this is kind of where I've came up with this from. Your autonomics, you have to be able to deliver fuel to an area. You have to be able to deliver blood to an area so it can work. If you're delivering blood correctly to an area, you need energy for the cells to work, whatever system it is. We all break down sugars to get energy. If you do it with oxygen, you get 38 ATP molecules for your cells to work. If you do it without oxygen, you get 2. So that's the anaerobic side. You're going to fatigue really, really, really quick if you only have 2 ATP molecules for your cells to work. So if you keep doing the exercise, I don't care what exercise it is, you're going to fatigue, and you're going to break that muscle down that you're trying to use. So you're going to get a little nociceptive response, pain, okay? That type of pain fires with type C fibers, okay? I'll give you one guess what type of fibers sympathetics fire with that we're trying to shut down. Type C fibers. So if you're doing an exercise and the goal is, hey, when you feel pain, stop, or you feel a discomfort, stop, you've already missed the boat. you're dumping lighter fluid on the area we're trying to tamp down. You have to have some sort of autonomic function or way to evaluate the autonomics to know you're not getting into that excessive area where you're activating pain, activating nociceptors, and seeing that sympathetic response. You also have to stabilize yourself first, right? Because if you move and you don't stabilize yourself, that's the thing where the pen's rolling off the table, you move real quick and you go, oh my gosh, my back. You didn't stabilize yourself well. How many EDS patients move and throw their back out, throw their shoulder out, throw a rib out, right? You don't stabilize yourself very well. You shouldn't, my opinion, those are the two things that you have to really get down. And a lot of the stabilizing regions in the brain are through your vestibular system. And so we should be evaluating the 3 semicircular canals, the 2 otoliths, and the 4 vestibular nuclei that are there. So that's 9 areas that we should be looking at to say, how's that function? Because those are the areas that help stabilize you from a reflexive point of view. But you have 9 on one side, 9 on the other. So it's actually 18 areas that I look at when I treat a patient to say, how is this functioning before we start? Oh, I know this is probably sounding bad to some people. It's not meant to, but like to get you on a treadmill and just say walk. Like if a person can't deliver blood when they're standing up, their motor skills aren't good. Do you want to throw them on a treadmill for 20 minutes, have them walk with no arm swing, head down, they fatigue themselves, and then they cancel the next visit because they're in bed for 2 days, and they're in this cycle of not getting better? I mean, I see that all the time. So I think, but you do have to move, but you have to be ready to move. You need resistive exercises, but you have to be ready to do the resistive exercises. You need to be able to resist gravity first before you can stand up. Like you don't take a 2-month-old and say, walk, do you? Why? Because they haven't developed that system yet. So, okay, I'm off my soapbox. Next slide, please. So I think this is it. EDS patients, I think you have to start with the autonomics first to get that stable before you start doing anything else, because that's blood delivery. You need blood delivery to muscles. You need blood delivery to brain. You need blood delivery to gut for it to work well. How much do you want to push a system that's autonomically not functioning well? Probably not a lot, because you're going to go into that anaerobic side and it's going to actually cause more sympathetic firing. And you have to stay within the metabolic limits of the tissues that you're looking at. Next slide. Yes. Oh, 12 minutes. That was really bad. Sorry. I'll be here as long as it's needed.
I'm just going to put up this other slide that's got Dr. Lasko's contact information. And thank you so much, Dr. Lasko. And
oh my gosh, it was a pleasure. Thank you very much. Thanks for everybody. I never thought there was going to be that many. I'm very humbled. Thank you very, very much. I hope this was okay.
Okay, we have a lot of questions that are in the chat.
I saw them.
I don't know if you want to try to pick them off. Like some of them I tried to answer that I felt like I could safely answer, and others I thought I could answer that, but I really want to hear what he has to say, so I didn't. So if you can maybe start from the top and scroll through, and then if people want to raise their hands in the little icon, I'm gonna see if I can get back to gallery view here so I can see everybody.
Is there, Elizabeth, is there a way to like, oh boy, globally, like are there general questions that might be like specific? I will be very honest, specific questions, and I was looking through some of them, but I was more focused on the slides, like what to do for X or what to do for Y is very difficult for me to answer And it's not because I don't want to, it's because I don't know what your neurologic system is. Like I can give you a real quick example. And again, I could be here as long as you need. I had a movement disorder patient, one of my very first patients, real good result, did really, really well. And I'll never forget it because it was a night like tonight. And I think it was like 9:30 at night, office phone rings because we have a cell phone for the office phone, and it's from Brainerd, Minnesota. And I answer it, and there is this frantic mom yelling at me on the phone. And I mean this. What did you do? You know, my daughter has these movement disorders. She's in the hospital. We don't know what to do. Your exercises did this. And I'm trying to think of like, who in the heck? I'm trying to mouth to my wife, like, do we know Sally Smith? You know, no, I don't know her. The exercises were given from the one patient to the other, and it wasn't appropriate for that person. It was actually, she actually became a patient. And I mean this when I say this, it was 170 degrees opposite of what that person should have been doing. So to clump in, like, and if there are any, I could try, but I don't like doing that because your nervous system for the EDS, well, everybody really, your nervous system is individual to you. Your sensory processing is individual to you. Your neurologic exam shows individuality to you. You are zebras, right? I don't like protocols. I think, and I hope this doesn't step on toes, but I don't print out, I don't have pre-printed things that I say do 3 sets of 10, 2 sets of 5. I try to teach the patient these exercises are going to be good, but you have to look at how your metabolic rate is. How is your perfusion? How's your pupils? How's your blood pressure? How's that? And that has to be, in my opinion, that's going to be the best thing for these patients because not everybody needs 3 sets of 10. What if you're doing an exercise and at the second set, your arm starts to burn? Well, do I keep going or do I stop? I would personally stop, but it says to do 10. Should I keep doing it? Because I don't want to not do what I was told to do. So if there's questions like that, that's going to be really hard for me to answer because I don't want to give somebody, I wouldn't give this over the phone. I don't do Zoom stuff because I can't evaluate the person in a correct manner via Zoom. So I could try to zip back here and do as good as I can. Oh boy.
I know there was one question early on about, is there a definitive test for tethered cord?
Oh boy. I don't know of one. I think it's one of those things that are like, if you have this, and this, your urodynamics are not correct. The MRI shows that it's tethered. I don't know of one that's like a gold standard. No, I do not. EDS all my life. Stomach gastro took 80% of my stomach. Oh boy. Yeah, I mean, yeah, if you don't have 80% of your stomach, absorption's going to be really tough. Absorption's going to be really, really tough. CRPS after, yeah, a lot of EDS patients have CRPS because, I mean, that's, again, are you delivering blood to your end organ very well? Like, are you delivering blood to, if you get a fracture in a wrist or whatever, are you going to be able to deliver, and I hate saying this, but are you going to be able to deliver blood as well as maybe I do if you have EDS? Probably not, because you probably have higher sympathetic tone, and that means you're not able to deliver blood to that end organ at rest like somebody who doesn't. So yeah, you're probably going to have peripheral neuropathic things going on, definitely. Heather answered that. Sorry. is essential head nodding part of EDS? Does that mean like constantly saying yes, like your head is just kind of tremoring? If it is,
Yes.
if it is, that's a movement disorder, and I would really look at teasing out what part either of your vestibular system, spatial stuff, or proprioceptive system isn't working well. Because that, in my mind, if you're constantly nodding, your brain is asking it, give me some input to tell me where the heck I am. And it's trying to get feedback. Like if I stand behind, well, I don't anymore, but stand behind somebody in church and they're constantly swaying back and forth, like that person doesn't know where the heck they are in space. Their brain is screaming for input. That's why they're moving. They're trying to give their brain some input, and the more you sway, the less you know where you are.
It's not constant. It's when I'm sitting still, it will just start nodding.
So when you're sitting still, like how much input are you getting? Not a whole lot, right? So if your system isn't like at rest, you should have enough reserve built up for you to handle being able to sit still without giving your body more input. You stop and your body's, if you're not functioning well, your body's going to need input. That's your brain screaming for some sort of sensory input. You just have to tease out literally which one of the 18 vestibular inputs, spatial, proprioceptive areas are you lacking in. That's how I would start. Bone scan can be effective early on. Osteoporosis, sure. Yep. Multiple medications, absolutely. Zebras on parade. So helpful. Thank you.
There was another question about vitamin malabsorption. Is that common in EDS?
Any malabsorption. I mean, again, don't want to step on toes here, but there's a lot of people that prescribe probiotics, all the vitamins and stuff like that. They're good. Don't get me wrong. My patients are on them. I tell them to get on them. But doesn't your gut have to work first?
Yeah.
You know what I mean? Like, doesn't your gut have to work first before you can start digesting some things? That's how I look at it, and it's probably a juggling act between both of them. But if I see a person who has a bowel movement 3 times a month, probably not going to say get on some probiotics. Why don't we try to activate the gut to try to hear some bowel sounds, to maybe start going once a week and then twice a week and then maybe every other day. And then like once the system kicks in, then can you get that system a better flora and all the rest of that stuff that's in there to make it work even better. Could you sprinkle some in? Sure, but if you're not getting rid of anything, is it just sitting there?
Well, we
Right?
could take a live question from Sunshine.
If you tell me how to do it, sure.
Hi.
Okay.
Hi,
Sure.
this is Sunshine. I had a brain scan and I have micro blood vessel damage
Mhm.
and I have a malformed brain. Could
Yep.
EDS cause that?
Oh boy. Anything like that in your family? I mean, is there
No.
any genetic connection or anything like that?
No.
I've never heard of, like, when you say malformed brain, is it smaller? Is it like hydrocephalic? Is it or what?
The right, I forget what it's called. It starts with a P, the right,
Parietal?
yeah, where you retain information and stuff, it is smaller. And there's more white matter.
Well, I'll tell you this. and this is going kind of off what we were talking about, but have you had COVID?
No, I had it. Yes, I had it twice, but I had this before.
Okay, so your brain expand, like, I'll give you this as an example. A newborn infant brain, and I'm going to be off with this a little bit, but just get the idea because I kind of forget this. But say a newborn's brain is 900 grams big, okay? By the time they're 18, 20, 24, it might be 2,700 grams big, with weight. How did it expand? It's by sensory input, right? I mean, you lay down myelin, you make different connections. Your brain grows because of the input, because of the input coming in, you need more roads or pathways to develop. If you say it's on your right side from a sensory standpoint, like, how does your left side feel? Do you feel things on your left side correctly? I mean, you could have had, I'm going to say, like everybody would understand, like a mini stroke over there. You may not just be delivering enough oxygen to that area or blood, and it's just not growing. Like if you don't use your right bicep, it's going to be smaller than the left one that you use all of the time. I haven't, EDS is still kind of new. So I think people like yourself, Sunshine, like those type of things, 10 years from now, it might be, yeah, EDS might have a cause in something like that. I personally haven't heard of that.
Okay, thank you.
Yes, ma'am. I'm trying to go down here. Zebras on parade. Can full tilt table provide a differentiation, the root cause of dysautonomia? Yeah, if they gave you nitroglycerin, they were trying to, Zebras on parade, they were trying to really get things going. Can a full tilt table provide a different? Yeah, I think it could, but the question was, can a full tilt table provide a differential diagnosis for adrenal issues causing POTS or other root causes? I'm sure it could. Yes. I think from a treatment standpoint or an examination standpoint, you should be able to tease out, is this a hyperadrenergic type of a orthostatic thing, other than maybe doing the whole tilt table and really cranking your heart rate up and seeing how you respond. Nobody likes that done. Next one, does it matter which direction the BP drops along with heart rate? BP standing 106, high heart rate. BP with tank laying down, heart rate would also drop. Yeah, TY to everybody. Yeah, I mean, all of those things, it definitely does matter because, like, I've seen patients where you do an orthostatic test on them, and if you have them stand for 5 minutes, 6 minutes, you might be sympathetic, like your heart rate might be high, and your heart rate might be high, but your blood pressure is okay for the first 4 minutes. And then all of a sudden, your heart rate's high, and now your blood pressure starts to creep up, and all of a sudden your blood pressure starts to get higher and higher. Yeah, that should tell the doctor something of your system doesn't maintain upright posture well for a long period of time. And that's a really good window into saying, hey, how long can you be on a treadmill? How long can you exercise upright before your system starts to hit the fan? So, yeah, I mean, I tell you what, you could tease a lot of stuff out with autonomics, formulating treatment plans for patients, if you understand what the autonomics are actually telling you. You really could. You really, really could. If your heart rate is sitting over 100 and you are already on medication, should one talk to a neurologist, or is there another specialist? I mean, if you're on I'm going to assume a beta blocker and your heart rate's still over 100, the default is going to be more, like, sounds like I'm picking on people. I'm not, but the default is going to be more meds to try to get your heart rate down instead of what the heck is what, like, generally, I think EDS patients with all these comorbid things, the end organ is treated because evaluating the control mechanisms in the brainstem are up. They really don't know what to do with that. They don't, like, what are they, if I were to tell a neurologist, hey, they have a tectal area that's I think driving it, they're going to order an MRI and nothing's going to be there, and they're going to go, well, how do you do that? It's by an examination. Like, how do you inhibit that midbrain area? So, because that does have an area that can control or alter heart rate or blood pressure or autonomics just in general. Like, what are they going to do? Their tool bag is, and I hate saying, but meds, where they're treating the heart, but nothing is really wrong with the heart, right? Nothing is really wrong with the gut, but they're treating the end organ, not the control mechanism that's making the end organ not work correctly. I hope that answers.
One question that kind of relates to that is, like, how do you describe brain-based therapies? Like, could you give an example?
Sure. So if we're doing something to a patient, and say, let me see if I can get a scenario here. Let me write this down real quick. So say a patient, from a doctor standpoint, most doctors do a test called Romberg's. You have them stand there. Their arms can either be out or down by their side. Say if the person just sways right, so center to their right, center to their right, center to their right, okay? From my perspective, that tells me something right off of the get-go. And a lot of people would say, oh, it's the right side, that's the problem. Not necessarily, because one test doesn't show the whole thing. But say we look at somebody's eyes, okay? Say we do cardinal fields of gaze. Most doctors, therapists do cardinal fields of gaze. What if, when you're doing cardinal fields of gaze and you are moving to the, I'm going to make sure I do this right. Say you're moving their eyes to the right, and say their eyes overshoot when you're just follow my thumb and their eyes keep going to the right. Okay? That should tell you something that's going on in the brain. Say they have a little left head rotation. Okay? That, in my head, just with those three things, that would tell me the problem's not on the right side. It's a left-sided, probably cerebellar or a vestibular problem. So then what I would do is, can I come up with some exercises that might activate or inhibit, depending on which one it is, that left side? And then say we do different eye exercises, balance, cerebellar stuff. Say we test them in that Romberg's position again, and they're steady. Well, guess what? That becomes one of their exercises to take home. Say we do some eye exercises or some head motions, gentle. If it improves, that becomes one of their exercises. But you have to be able to correlate those three things in this scenario to get an area of the brain that's not working correctly. And if that correlates to making them stand up better, resist gravity better, their eyes move better, that's a better functioning system, right? Because the input is now more correct. You should get a better output. Does that help, hurt?
That helps me. I think that
Okay.
might help. Yeah, thanks.
Okay, I'm going to keep scrolling down here. Dittos. Is there an association? Is there a known association of idiopathic hyper? I don't know of one. Hypersomnia. I don't know of one. Do I recommend prism glasses for binocular? No, I do not. I would try some eye exercises to, again, and it's not the easiest thing in the world, but can you do some eye exercises or vestibular stuff or cerebellar stuff to try to improve the eye motility before you start putting prism glasses on? Not that they're bad. I'm, again, ultra conservative when it comes to treatment. Could this correlate with research being done, comorbidity of integration? Oh my gosh, yeah. Aubrey, Derek, yeah. I mean, and it's it's not that EDS, I'm going to say this correctly. The connection between EDS patients and like ADHD or autistic tendencies or perseveration of thought or OCD problems, if you take a step back and if you remember that things like anxiety, perseveration of thought, OCD, ADHD, autism, isn't that a lack of inhibition? I mean, in the grand scheme of things, just keep it simple. They are not able to inhibit the thoughts from running, the OCD tendencies, the anxiety, all of that stuff. I used to have a fairly good practice treating, I'm certified in neurodevelopmental stuff. And these same types, if you want to, of therapies I used on my ADHD patients, they got really good results. It wasn't because they had EDS, they had inhibitory mechanisms in their brain that just were not functioning correctly. So yeah, there's going to be a correlation between that, because it's not, I think the EDS input or the abnormal input that you get from the muscle and joint and the connective tissue alters the brain and the brain function in a way that allows those inhibitory mechanisms to not function in a correct manner. So you have these escapes at various areas in your brain function. This is right on. Thank you. Okay, thank you. OMG. Keep going up in the gabapentin. Gabapentin causes bone loss. Yep, motility issues. Question, can you expand on example on options? Christy, expand on examples for basal ganglionic therapeutics. I could, but I am very hesitant to do that. And it's not because I don't want to give you something to help. It's just, I don't know if I tell you to do complex motions and you try them or a friend tries them that you're asking for and stuff hits the fan, I would feel like snot. I really, really would. But if you go back and look at that basal ganglia slide where the pluses and minuses were on it that I made, that I was so proud of, each of those areas that are written out could be evaluated to assess their function. And once you understand what that function is, or abnormal function, the therapeutics are just about targeting that area and see what type of output you get, meaning, do you move less? Are you able to move in a more fluid manner, or whatever the case is? It's not that I don't want to, it's just, I know that if it's wrong, stuff could really hit the fan and cover everybody in the room. So I apologize. If you have specific questions, I'm going to say maybe call and we could talk about it, I think. Yeah, bruxing, definitely a hyperkinetic movement. you're going to have to ask them if you can get a copy of the slides. I'm assuming yes. Post them on Facebook. Good. I guess I should read the answer below. Thanks, Heather. Best test for tethered cord. Again, it's one of those things where, boy, urodynamics, the symptoms, imaging, and just that's what I would say for a tethered cord. That would be my answer. I don't think there is a best test. What type of doctor tests the autonomics? I mean, cardiologists can, neurophys can. You know what? I think it's in the interpretation of the test. I think that is the key with, just like that example that I gave, I think Elizabeth or Heather asked about, like, what do you mean by brain-based? I've seen people bringing in their folders with examination findings, and I'm doing eye tests, and I'm like, wow, do you know you have a convergence problem with your left eye? No, nobody's ever told me that. I was at the eye doctor last week, and nothing against eye, but I mean, you got a convergence problem with your right eye. So maybe he didn't come all the way in, or she came all the way in, but like, that's a problem. So I think it's the interpretation of the tests that you get that, again, rule out all the pathology, but like, what does it mean? Like, what does that test mean from a physiologic, neurologic point of view? And ultimately, what type of treatment can you derive from that autonomic test, your physical exam, your neurologic exam, your orthopedic exam? What type of treatment can you tease out to help the person that's sitting in front of you? Not just having somebody stand up and say, wow, I'm a little dizzy. Oh, you have POTS. We're going to get you on this POTS protocol from the various people that came up with the protocols and all that stuff. It'll work some of the times. I think a lot of people on here know that sometimes it doesn't, and it hits the fan a little bit. Okay. What are the ways? Oh, Christy, you're killing me here. Very good questions, but what are the ways you can stabilize the 9 ourselves? It all depends on which one is faulty, and there's no like one. Your vestibular system integrates proprioception, visual stuff, hearing, moving in space. So which one of those are faulty? And then what, if there's a faulty input, which one of those areas in the vestibular system are failing? Because certain areas of like your vestibular nuclei, some of them control extensors in your upper extremity, neck and back. Some of them do your legs. The therapies or the exercises might be different for each one. So I think everybody here, if they're still here, it's like my care is super individualized. And I really got that from just really listening to patients, seeing them, what works, what doesn't. I'm not a person that puts out like I said, puts out a copied sheet that says do 5 sets of 5. I think doctors can do better with EDS patients. I think the more individualized the care is, I think the better results you get, and you'll respond better to other disciplines that you're going to see. That's just my own personal opinion. Oh, Peyton, thank you. Valerie, thanks. Mobility aid recommendations. CJ, I mean, anything that, boy, anything that can help you not throw a shoulder out or a back out or a knee out. I don't have any specific ones that I do. I do tell them honestly. yeah, I mean, I don't have anyone that I say do this or do that because you have this.
One of the questions was just about getting insurance coverage. This is Heather.
Yes.
And
Well,
so that might be nice for people just to know, like, is kind of the neuro retraining therapies you're talking about covered by insurance?
Some of them are, yes, because what we do, we give, in the office, I have to bill with regular chiropractic physical therapy codes. So we've had a lot of patients that do get reimbursed for the care. I use examination codes, gait training, neuromusculoskeletal re-education, like self-care, home management. It's basically physical therapy codes. So if you have coverage for physical therapy chiropractic, you should have some coverage. But what we do, we tell you kind of the codes that we use, and then before treating, and then you can contact your provider and say, you know, hey, do I have any coverage for these codes? So you can do that, and we would give that to you before. Zebras on Parade, like to connect with my chiropractic neuro in Idaho. He kept me walking out of fusion treats, but he could learn a lot from you. Okay. Yeah, Medicaid is not exactly favorable to a lot of providers. I don't have any movement disorders. Do you think I don't have EDS? Not necessarily, Patty. I mean, oh, sorry. Sorry, I didn't see that was a direct message. I'll try to get back to you. Sorry. Question, any tips about getting insurance coverage, EDS, try traditional medicine, vestibular. Insurance won't cover it. Yeah, I don't it says to everyone, I don't know why insurance wouldn't cover treatments if we use the right codes that your insurance covers. I will say, and this is probably going to step on my own brethren's toes, but a lot of doctors, I'm just going to throw that out. A lot of doctors still don't appreciate EDS. I'm just going to tell you that straight up. I talked to them. I talked to many different specialties in my area on phones. The one example I gave of the young girl that would tip her head and her heart rate went up to a 140. The comment was, I've been a chiropractor 30 years. You adjusted her neck, right? And I'm like, are you kidding me? You know, so I think I think it's not necessarily the name of the person or the doctor this or doctor that that's important. I think, do you understand EDS is the question that I would really ask, because that's really important. Because if this is just my opinion again, I've seen patients that have had things done to them that I wouldn't do in a million years to an EDS patient. And you know, whether they understood EDS, not understood EDS, some specialist, and I think that word is thrown around a lot, like maybe shouldn't be in EDS. And I'm like, really? You're doing, you know, high velocity neck things with an EDS patient? I don't know if that's the best thing to do. So I think it's the person that's treating you and not necessarily what the two letters in front or behind their name are. That's really important. Everyone, what to share it with the psychiatrist who gave gabapentin. I would ask them why, and then ask them if you have a movement disorder, ask them if it's a right or left-sided gabapentin, and then see what he says. But that's just me. that was to Lisa. We get a copy of the recording, I'm assuming. Emailed you, Oregon, YouTube. CRPS, suffered most of my life. That helps. Janet, it was to everyone. Yeah, I see that a lot. Gastro, CRPS, and SVTs. That's the sympathetics that needs to be, in my opinion, functioning better. But also appear to maintain a practice where you recognize there's even there's going to be bonkers. Do you have a script for how a patient can talk to a doc about it? I'm concerned that if this treatment is going to jolt TF out of my look at it related. Aubrey and Derek, that was to everyone. As a physician who recognizes protocols don't work well for these, but also maintain a practice where you recognize zebra system can be bonkers. Do you have a script for how patients can talk? You know, Aubrey, Derek, it was to everyone, so I'll address that. The question I would always ask is, from a therapy standpoint, if somebody's doing therapy X on you, why? And doctors are not going to like that very much, but why? You know, are you a set? What are you looking for? What are you trying to accomplish from this? Why? And within 3 or 4 questions of why, probably 2, you'll know if they really understand, from my perspective, like autonomic function. You'll really understand if they get that this can't be, you know, we're going to do what's on page 38 of whatever book, manual, whatever. That's going to come out really quick. And usually the more upset they get with that question, that tells you a lot from my experience in talking with other doctors. You know, why did you have them do that therapy when, and I would explain X, and they usually don't, within a couple questions, you're going to have your answer. Let's see here. Bit of opposite problem to find. You should often have what seems like the opposite problem of what you're talking. Find inside my body doesn't respond. Huge effort. Don't feel the strain. Definitely, this could be wrong. Sometimes I feel some overstimulation. Calming. Adrian, you might be one of the few that top-down stuff might work with, but I don't want to say that, like, don't take that as the 11th commandment. Because sometimes there's no way, and this isn't against you at all, so please don't take it that way. There's no way anybody here could give me a list of things and say, what do you think? I mean, I can give you a ballpark, but a lot of times, like you say, you have to move your leg slowly because it's sore and stiff, and moving it faster is difficult and hurts. Could that be an overactive basal ganglia? Sure. Could it be a pain-producing thing where, like, you have that anxiety that you think it's going to hurt, and it's, you know, and that type of thing? It's not your fault, but it's just one of those things that you have to tease out. Not you, but collective. We would have to tease out, like, why is that happening to you? Because on the occasion, you know, there's different neurologic things that could happen to give you a neurologic output that makes you not function in a correct manner. So I'm sorry I can't help, Adrian, but what I would say to you, good neuro exam. Does it correlate to what's going on here? Good orthopedic exam. Does it correlate to you feeling the way that you do, treat, how do you respond? That's what I would say. I'm sorry I couldn't answer that better. Yep, zebras, research mitochondrial stuff. You could have definitely a genetic thing going on again. That's kind of the bad stuff. But on the flip side, could it be that you're just not oxygenating the tissue and you're just, there's no more gas getting to the engine? It could be that. How does COVID affect? Oh my gosh, double X to everyone. Boy, look, in a nutshell, it was a question about COVID. COVID is a viral thing. So generally, viral infections love to hit that basal ganglia. They just do. And if you alter function of the basal ganglia, you're losing some of that inhibition. And I took a COVID seminar talk recently, and there are very specific areas in the brain that are really affected by COVID. Brainstem areas are really hit. That's why autonomics are hit pretty hard with COVID. Basal ganglia is hit really hard with COVID, and that like medial prefrontal cortical area, like insular cortex area, is hit pretty hard. But the big thing they're saying is that, and this comes down to the autonomics, is that it is a hypoperfusion problem. Well, yeah, because when you get sick, your sympathetics go up. You know, when you have a cold or a flu, your sympathetics start to kick in. Your heart rate gets high, kick your immune system in, all of that. If you have EDS and your system is already at, 200 degrees of boiling of water on the stove, and you get a big viral infection, you don't need a whole lot for that water to start to boil. And that's what happens with COVID, especially if you do have EDS. And yep, it could increase POTS, it could increase all of that. The treatment is, how do you affect those brain areas that were injured or not getting enough blood to them? Can you get them activated again? And can your system, like, that's the one thing with my patients, I always tell them the first day, I'll let you know, is your system changeable? Like, because that's the big question. Can your system change? My first day, I do an examination. We really tease out some of the areas in the brainstem that control your autonomics. I come up with different therapies to target those areas. Can we see a change, say, in your heart rate? Can we get, and I had videos, and Elizabeth and I spent an hour, and it was 99.999% my fault that I couldn't get some of the videos on, and not Elizabeth's, but you have to be able to affect the autonomics. And if you can't, it's really tough to move forward. So we say, I tell my patients, first day and a half, I want you to objectively see, can we change how your autonomics function? Can we do therapies that lower your heart rate? Can we do therapies that you start hearing bowel sounds? Can we do therapies that would help you sleep? If you're seeing those changes, we're on the right track. Then it's just a matter of literally learning. Your system has to relearn how that is correct. And the only way you do that is by creating long-term potentiation, neuroplasticity, whatever you want to call it. And that's how we learn our multiplication tables. We learn our colors. We learn our numbers. Keep firing those systems within the metabolic limit. Because if you exceed that metabolic limit, you're dumping lighter fluid on the system that we don't want to activate anymore. Okay. You want to talk about how many patients are sent to therapists instead of physical health doctors, the cost of medical gaslighting? Oh boy, CJ. I do, but probably not the place to do that right now. Yeah, I think a lot of times if all that's in their toolbox is a hammer, there's going to be a lot of nails. And sometimes they'll even try to pound a screw in. That's why the question why is always good to ask a doctor. Why are you doing this? Why? Again, within a couple questions, you should get your answer. Hyperbaric, it's great if the person is ready for it, Becky, for hyperbaric. I look at it as this way, like your sympathetics need fuel to run as well, right? Your sympathetics need to run. I found that people, this is just my opinion because I used to have hyperbaric at my office. Once the person is regulated a little better, hyperbaric works a lot better than if they're already in that fight or flight stage. That's just my findings. I don't want to. Oxygen is great. Hyperbaric is great. I just don't. Here comes one of my dumb examples. I would rather weed my garden first and then fertilize it than just dump a bunch of fertilizer in the garden that has a bunch of weeds and plants. I would rather get the system working really well before I start giving it more fuel. Okay.
Dr. Lasko, I think Elizabeth has one more question. We're gonna
Gosh,
have to
I'm sorry.
we're gonna have
Yes.
to wrap up pretty soon. And I
Okay.
think just having,
Sorry.
I tried to scroll through as many questions as I could read, and a lot of them ask similar things.
Okay.
Go ahead, Elizabeth.
Yeah, I just wanted to say, yeah, we probably should wrap up. I really appreciate you, Dr. Lasko, spending so much time with us. It's wonderful.
No problem.
And I'm wondering because, we're obviously quite a distance from you being out here in Oregon, how would someone go about working with you, being this remote? Do we need to go there? Do we call you? What do we do?
This is what I'm going to do this, and my wife's probably going to have well, she handles it, so she's going to love this. If somebody is, and this was not to get patients, I did not do this for that reason. I just think you guys need this type of information because I think it's really important, and I know that it works. But if you're interested, I do a 15-20 minute half-hour consultation. I don't charge a penny for it. I'll talk to you. Usually you could send like bullet points of diagnoses, what your symptoms are, all of that. And I'll give you an idea. I think I can help with this. This probably isn't in my, wheelhouse. This, not this, and this. And then it would be, coming out here. Telehealth is so hard to do. I tried it. And honestly, I just didn't feel I was giving the patient the correct amount, because when I do an examination, if I'm looking at the eyes and if your feet move when I don't want them to move, that tells me something. I can't see that with, telehealth. You would stay here. We have a family. We are so blessed. They open their house completely free to any of my patients that come here. They don't charge a penny. They've been doing it for years. They have a beautiful, probably 5,000 square foot house, and it's ADA compliant. They actually sold their one house to buy this house because their other house wasn't ADA compliant. So they actually did it for my patients. You basically have your own wing, and they don't bother you. They don't cook or clean for you, but they will not take payment. They just won't. But yeah, my office, I only see 2 patients a week. I spend 3 hours with you, 4 hours with you. You can have follow-ups that I don't charge for, as far as like phone conversations or like emails. If we can work through, if I spend 15, 20 hours with a person, I kind of have a good idea how you function. Then we can do a lot of this stuff via either email, phone call, Zoom. that can keep you progressing on the way down. And obviously Heather's here. If we, that's a good source to kind of hand the ball off to once you get back to your neck of the woods.
Oh, well, that sounds great. That is so generous.
Oh,
Uh,
it's a blessing. It really, I get kind of teared up just thinking, because it's just amazing. And they're so nice. And actually most of the time they're not even there, so you have the whole house.
And are other chiropractics training in this, or is there any kind of like getting the word out so that there might be people who practice this out our direction?
I hope so. And I'm sure there are chiro neuros out there. Again, I don't think our profession is special in knowing all things about EDS. A lot of them, I will say this because it's just the truth, a lot of them will give the exercises or therapies off to a therapist to do, and they see another person. So it's not one-on-one that I know of. My care is very individualized, and it's me, my wife, and the patient and the significant other family that come. It's one-on-one, and it's specific for the person.
Wow. Well, that sounds great. We don't get that kind of attention like we deserve. So,
You should. You guys should. You're zebras. You need the individualized care, and I'm not saying that tongue in cheek, because you really do. Your nervous system. I've seen enough of EDS patients. Same type of comorbid things, different areas of the brain can affect, and you can still have those same comorbid things.
Well,
Any of the questions, if I could real quick, any of the questions that I didn't get to, if they want to email me, you have it there. I'll try to answer them as much as I can, as well as I can. I appreciate it. Thank you, Heather. Thank you, Elizabeth. You've been a rock there with all the all the computer stuff. Thank you so much. Heather, thank you.
Right. Thank you.
Appreciate it.
Thank you
Thank
so
you
much.
so much. Thanks everyone for attending.
Thank you.
And we'll get this posted in the Facebook group, and then you can email info@oreds.org if you want a copy of the slides and the link to the presentation. And then I put, we do have our little YouTube channel, and I made a couple things public that we had from previous at the, it's in the chat. So if you're not sure, info@oreds.org, and we'll email you that again.
Thanks again.
Thank
Careful.
you. Have a great evening.
Thank
Bye.
you. Bye-bye.